Okay. So we're going to talk about MuSK today in neuro, and MuSK stands for muscle-specific kinase, and it's a test for a specific form of myasthenia gravis that is seronegative for the usual cause, which is anti-acetylcholine receptor antibodies, binding, blocking, and modulating. So if you're negative for acetylcholine receptor antibodies, our second line test is going to be MuSK. And as you know, at the neuromuscular junction, we have acetylcholine release, and that's going to bind to the acetylcholine receptor, and that's going to activate neuromuscular junction firing. However, this acetylcholine receptor is complexed to adjacent receptors that also could cause the same expression of the disease, which is myasthenia gravis clinically, and that is the LRP4, the lipoprotein-related protein 4, and the MuSK, muscle-specific kinase. There are also striated muscle biomarkers that can be positive, even though they may not actually be pathogenic, they just might be epiphenomenon of the disease. And those are the titin antibodies and the striated muscle antibodies. And so those would be what we call third line testing. So you got seronegative, MuSK would be double seronegative, and the LRP4 and the striated muscle antibodies would be triple seronegative. The reason you need to know about MuSK is it can cause ptosis and ophthalmoplegia, but it's not as prominent as in the acetylcholine receptor form of myasthenia gravis. And the limb involvement in generalized myasthenia for acetylcholine receptor positive myasthenia is not as prominent in MuSK. So the things that are prominent are a dangerous thing, which is bulbar involvement. So bulbar greater than limb and greater than ocular myasthenia gravis symptoms. And those bulbar symptoms are like speaking and swallowing and could cause respiratory distress, and so it's potentially life-threatening. So the probability of having a respiratory crisis or a life-threatening problem is higher if you are seropositive for MuSK, even though their limb involvement and their ocular involvement might look mild. The other thing you need to know about MuSK is it tends not to respond to certain therapies that are useful in acetylcholine receptor positive myasthenia gravis, including thymectomy. And just like with ocular myasthenia gravis, the mestinon and the pyridostigmine don't seem to work as well as prednisone and immunosuppressive agents in MuSK. So we're less likely to use thymectomy. You shouldn't be surprised if we don't get a good response to the mestinon. And all of these need to be managed with neurology because we were worried about the bulbar findings and they're going to have a higher risk of respiratory crisis. So you need to know about antibodies. Seronegative for acetylcholine receptor, we're going to go to the MuSK, double seronegative, and the triple seronegative LRP4 and the striated muscle antibody. If you have single fiber EMG, you might go to that first. But MuSK to me is important because it looks and acts differently, and its treatment is slightly different in terms of response rate.